Assalamu alaikum. Bismillah ar-Rahman ar-Rahim. I would like to welcome you all and thank Dr. Amany for her kind introduction. I hope the title, I know, is not clear, but my hope is by the end of the panel, you will know why I wrote this long title. First of all, I would like to welcome our distinguished panelists according to alphabetical order. Dr. Amany Shalaby, Professor of Audiovestibular Medicine, Ain Shams University. Dr. Sheikhany, Professor Phoniatrics, Cairo University. Dr. Iman El Professor Audiovestibular Medicine, Ain Shams, and Professor Ossama Sobhi, Audiovestibular Medicine, Alexandria University. Welcome you all. Let's start our panel with a very famous question. Do we hear with ears only? What do you think, the audience? We hear with ears only? Actually, we hear with our brain. Our brain contributes significantly to hearing. I remember when I was a resident in audiology unit, and Professor Salah Soliman used to say, God bless him, our late Professor Salah Soliman used to say, we hear with our brain, we don't hear with our ears. And by time it proved to be right. The brain contributes significantly to hearing. How? It starts where ears detect sound, and then the brain contributes by interaction of auditory skills, abilities for processing, and thus it gives a meaningful auditory information and executes a response. This occurs through auditory abilities that interacting in two strategies. First strategy is called the bottom-up strategy. This strategy, the bottom-up, starts lower down, up. And the second strategy is the top-down strategy, which acting from higher centers down, both interacting in order to process auditory information and to hear adequately. So, according to Dr. Frank Music, the auditory processing, and it depends on interaction between how well the ear talks to the brain and how well the brain understands what the ear tells it. And if the ear does not talk to the brain, the ear, by having a hearing loss, especially if it is persistent for a long time, fluctuating, or occurs early in life, what will happen? There will be no stimulation, and the brain loses the ability to process auditory information. Because the brain depends on stimulation, like the principle, use it or lose it. And then secondary APD will happen. And this is the point that we are going to focus upon by presenting cases to discuss how secondary ABD with our distinguished panelists occurs and its mechanism, and what can we do for secondary ABD that occurs following hearing loss. Let's start by first case. This is a male child, 6 years old, in the first primary school. The complaint is inconsistent response to sounds, with poor attention in classroom, difficulty following orders, with delayed language development. And from history, he has recurrent attacks of tonsillitis and middle ear problems. This is his audiogram. Dr. Ossama, what do you think from this? What is your possible? It is, I know it's very simple, but
It's apparent it's bilateral conductive hearing loss, moderate in the right, mild in the left ear, with excellent speech discrimination. Obviously, since the flat tympanogram, so it's expected that this is a case of middle ear effusion or secretory otitis media.
I agree totally. But do you think this is sufficient? Do you think this is sufficient to explain the complaint of the patient? As you see,
no.
He has.
Since we have to give like a low redundant stimulus in order to detect what's the cause of his problem. Because the pure tone audiometry and the speech discrimination, which is done in complete quietness, it does not reveal things like auditory processing disorder. We have to give a more tailored central auditory testing, which is dependent on low redundancy, so that we can detect if there is a problem with his central auditory processing or not.
So it is, as you said, conductive hearing loss due to otitis media with effusion. But due to the patient complaint, we should think, what is the next step? What is the next step, Dr. Iman, in your opinion?
What bothers me is this child are the third and fourth complaint. First and second could be attributed to an otitis media with effusion. So we have to see how much this delay is in speech and language, to refer for speech and language evaluation, to know 6 years old child how he is performing as regards receptive and expressive language. Of course, this is one item, and the second is to start with central auditory processing test because of inability to follow orders. But before this, we have to be sure that he has a normal IQ, because the IQ could affect with such degree of hearing loss and could lead to all these complaints. And of course, also, the vision is not that important, but we have to check also the vision, because these two senses are very important in academic achievement and in following.
I agree totally. We have to do psychometry to make sure of his intelligence, and the referral for speech and language assessment, I think, is very important. These are the first two steps. Next, referral for ABG after these two steps. Dr. Aya, is it common to have children with otitis media with effusion with speech and language problems? And what are the kind of difficulties they have?
First of all, if it's just one attack of otitis media, we don't expect that. But if it is recurrent and not treated properly, and the child, because some of the kids, they have otitis media and even their parents are not really aware of the presence of otitis media, this could actually cause some speech and language difficulties, some language delays as well. And given the profile of this child, the issue is that even his speech discrimination is 100%, yet this is only for words and short sentences. But when we assess the speech perception and processing, even through our speech and language assessment, it's for very long sentences following multi-step commands. So it's actually, even though this could be 100%, in our assessments, it could be totally different. And we have in the speech and language assessments something called auditory sentence repetition tests, auditory assessment of following commands, understanding oral instructions. This is what we find deficient in those kids as well. And not having proper access to sound is just not enough to have development for speech and language. Even if it's just a mild or a moderate delay, still it's a delay and it will affect him academically.
What about phonological errors? Is it common to have?
Yes, particularly for the high frequency sounds. Yes, and sometimes we suspect this. So if I get a child with everything normal and even his anatomy normal, but I find all the high frequency are lost, I suspect this, and then I go back one step back. Let's check your hearing. Let's see if there's adequate if there is an undiagnosed secretory otitis media or whatever is going on with his middle ear, because it's all one line that has to be absolutely working fine to reach the brain fine.
Actually, a study by Abdelaziz et al. Published in Journal of Otolaryngology focusing on the effect of otitis media and with effusion on speech perception. And it affects, as you said, the phonological development. This child, we did psychometry, and it was showed an average intellectual abilities. So we started the last station, which was auditory processing disorder assessment. Usually we start by questionnaire, and here is something that attracts me in children with OME, and our panelists may help me to know why. They have, of course, a problem in the classroom, memory problems, but many of them have difficulty to concentrate when with multiple auditory or visual stimuli are present. They have audio-visual integration problem. Any of the panelists can explain why this group of children suffer from audio-visual integration problem?
Some of those kids, other than the acquired otitis media that they had, some of them have something called developmental coordination disorder. So they have developmental coordination disorder. So it's a problem with coordinating multiple stimuli. Whether they are tactile, auditory, visual, they have a problem in coordinating all stimuli, integrating them together into a proper sensory system and giving a reaction based upon this. So yes, this is actually expected, especially because they could also have attention problem. It's not just an ear problem. You can have also underlying attention problem, which would affect more than one channel, not only the auditory channel. So yes.
Okay, thank you. This is the central auditory test results. I think it's Dr. Amany can help us and comment on this graph for CABG test results. We did a battery of testing measuring different auditory abilities. Dr. Amany?
Yeah. Can I comment on the previous? Can I comment on the previous of audiovisual integration? Because some of the studies said that the visual attention, when the visual attention is okay, and this otitis media with effusion is not prevalent to the child, and he has several attacks, so the coordination between the auditory and visual, sometimes the brain read it when there is no attacks quite well, the coordination is quite well, and sometimes when he is already in attack, this coordination is not present. So it leads to developmental discoordination between the vision and the audition.
Yeah, we have to be careful about this integration. Dr. Amany, what do you think about this graph?
Yes. As regard this, we have auditory processing disorder.
This is the norms, by the way.
Yes. The norms is the shaded area. And here for children, we look for the abilities, and we can see quite well that he cannot discriminate in background noise. We have a selective attention or competing problem with noise by the spin test. And again, we have a temporal processing or temporal ordering problem. He cannot put the things orders quite well. And this in the pitch pattern, which is the last shaded one. Added to this, the first test, the auditory fusion, it's 40 milliseconds, it's way beyond normal. So he has definite temporal processing added to the time compressed. So this, we can summarize this with selective attention and temporal processing.
What about this a complex ABR? Dr. Iman, would you like to comment on the? Dr. Ossama? This is electrophysiological measure.
Yes.
And by the way, we have a study on complex ABR in children with different disorders, including otitis media with effusion. As you see, this is normative, and these are the biomark, and this is the biomark score.
We can see that with 5 latency, it's within normal limits. With A latency is also within normal limits. The VA slope is not, the first form and frequency is not on high frequencies. Also, it's not within normal limits.
Denoting
that we have a processing disorder, especially we can see it not for the transient stimulus, which is the first part of the response, but we see it for the later responses of the speech ABR, as can be revealed from waves like F and O, E, F, O.
I can add that the offset wave is delayed and the C wave is not present. So usually when we see this, we can say that we have a subcortical or delayed brainstem timing, which goes with the findings of the psychophysical, that we have a temporal.
Actually, complex ABR helps to identify auditory temporal processing affection. When it is abnormal, you suggest by simple electrophysiological measure. This child have temporal processing, which goes hand in hand with psychophysical measures. So we have ABD secondary to otitis media and affecting auditory selective attention by low speech noise scores, temporal processing, and auditory memory. I would like to know, Dr. Iman, how frequent you encounter otitis media with effusion with development of secondary ABD or suspecting possible secondary ABD?
Actually, not that frequent. I can find auditory processing disorder secondary to hearing loss, but sensory neural more than the conductive hearing loss. Because most likely with the otitis media should be, to some extent, not mild otitis media, it should be significant hearing loss. And in such a case, most likely the parents will ask for help before the development of such problem. But we can see this in very young age.
Yes, early in life.
But they are not presenting to us. They are presenting to phoniatrics because of the delayed language development. The problem then is delayed language development, and when the phoniatrician sends him back to us, we discovered that there is otitis media, which could be the cause of such delayed language development. This is how it goes. But for older children who come to us, it's most likely they have a fully developed speech and language, and they have on top otitis media with effusion. So they are complaining of diminution of hearing, lack of concentration, or scholastic achievement, and in such a case, it's just most likely it's just otitis media. But I can encounter the secondary, but not secondary to otitis media, secondary to sensory neural hearing loss. Yes, I see this very, very, very frequently.
Yes, I agree. Yeah, to have ABD secondary to otitis media, it should be early in life. It should be long-standing and left untreated, maybe, and fluctuating frequently. The second question, what is the mechanism? How it happens? Dr. Amany, would you like to comment?
When the brain didn't, sometimes information reached from the ear to the brain fluctuantly, there is structure and morphological changes that happen so that the brain will not obey will have other way around, will take other plasticity form in order to overcome this, so it can act like this mechanism.
Yes.
Can I add something also,
yes.
Dr. Somia? It's that early in life, the kids need very, very good or almost excellent stimulus and speech so that they can develop their language. Before school, or even in the kindergarten and school, FS1, FS2, they could actually adapt and they don't report the auditory fatigue. But once they reach the primary one, where all the information is oral, like this child exactly, all the information is oral, it's all depending on clear stimuli. He cannot really compensate this when the breakdown happens and then when we get them. So it's all about the clear, just as you said, the ear and the brain have to communicate very clearly together. If it's not clear, then you get all this cascade.
Yes, I agree. Actually, this is a very nice study explaining the mechanism that recurrent, uncontrolled conductive hearing loss will delay sound transmission through the middle ear. And this inconsistent sound stimulus will result in structural and morphological changes with defects in sound perception. So it is use it or lose it. No stimulation, no processing. Secondary ABD. What is the suggested management plan, Dr. Ossama? If you have a case like this, what do you do for it?
Of course, treatment of otitis media is very important, and we have to follow up the patient in cases that medical treatment didn't get rid of the problem. Then we'll have to refer him for grommet tube insertion to make sure that the problem is gone. Then we will have to reassess the condition after resolution of the otitis media, just in case if the child has developed any kind of processing disorder during the period of the effusion, then we will have to take care of it. But in most of the conditions, if the condition is mild to moderate, usually there will be no associated problem, and that's it for the treatment of the case. But if we have a case of glue ear or prolonged deprivation, then that's another problem. We will have an auditory processing disorder, which should be treated then.
Dr. Wafa.
No. Because cases of cleft palate are usually detected early. They are detected from day one after labor, and they get grommet tube or even T-tube in cases, so they don't have prolonged durations of hearing loss. Mm-hmm. Yes.
Yes, you are absolutely right. We see many of them with delayed language development. So we should be cautious that they may have secondary ABD. Of course, if it is proved by assessment after control of otitis media with effusion, they have ABD, we go ahead and do auditory training programs, and they proved to be effective. This is an example of temporal processing training using nonverbal stimuli to stimulate by tones in this child. Let's look finally to the outcome of auditory training. Before and after for different tests that assess different auditory abilities. If you look, there is improvement across different, especially temporal processing testing. The surprising part is that memory improved remarkably from 3/3 to 5/5, which is very promising, denoting that improving the other abilities could improve the memory by minimizing the load on the cognitive aspect, which is a very nice explanation. Let's go to finalize this case. Recurrent attacks of otitis media with effusion in early childhood. Here, early childhood, Dr. Wafa, is correlated with auditory perceptual problems. It is recommended to check ABD especially if there is speech defect or learning problem. And this is my advice to the young generation. That's it, and I have treated the otitis media with effusion, and it's back to normal. Still, the child is suffering. He has a speech problem, or when he goes to school, starts to suffer. And adequate intervention can give successful outcome. Can I add something? Our panelists would like to comment on this red flag? The audience?
I can add something to convince and increase the awareness of parents, because they usually are not convinced that they have a problem. The child will take the medication and will be good, and that's it, and will not relate the learning problem with the hearing problem. So this is an important
I agree. If left untreated, it will be a problem. But if treated and controlled, it will not be a remarkable problem. I remember when I was with Dr. Robert Keith, This was surprising for me. He said that 1/3 of children with otitis media with effusion have auditory processing disorder. And this was a surprise for me. How? 1/3 is a big number. Now, after working for many years in this area, yes. And if you take the history for kids coming for ABG assessment, they give positive history of recurrent attacks of otitis. So my advice, especially for our junior staff, is to take this in consideration. Let's go to the second case. This is a female patient, 9 years old, in the 3rd primary, referred by phoniatrics. She came with bilateral diminution of hearing and was fitted with 2 hearing aids at the age of 5 years and received regular speech therapy. And recently, she's under speech therapy. But the problem, her mother reported reading difficulty and poor spelling at school. So she has a learning problem. No history of middle ear problems. That's why we ask on this routinely. And she has average IQ. And she has delayed language development with multiple phonological errors, in spite of having the hearing aid and the regular speech therapy. What is your comment, Dr. Iman, on this audiogram? Type A tympanograms.
The child has a bilateral moderate sensorineural hearing loss with good response with the hearing aids. Speech discrimination is good, it's not excellent. And the saucer shape could point to a heredofamily, which means that the hearing loss could start earlier than what's detected. And it was detected because I think he was fitted at the age of 5 years, which is
yes, this is surprising. Yes.
And he was fitted at the age of 5 years and most likely has some degree of hearing loss earlier in life. And till diagnosis, it took some time. And this could lead to some problem because, as I told you, sensory hearing loss, I saw many children with sensory hearing loss who have some degree of processing. It's not a pure central processing disorder, but have some degree of disorder which affects their performance generally.
Yes, I think, Dr. Iman, you agree with me that the aided threshold is satisfactory.
Yes, it's satisfactory.
Yes, and the child is not doing well. Why?
Can I have a comment on bus speech discrimination? That the discrimination here is 80% and 76% within the quiet setting and within very short stimuli. Can you imagine this discrimination in a classroom, in noise? How far will it go down on a sentence level? Multiple commands, kids talking around her, noise, fans, windows open. This discrimination will definitely drop. So
yes,
this will
I
lead
agree.
to a lot of difficulties in the classroom.
Dr. Ossama?
Yeah, I add another point. This is child with saucer-shaped hearing loss, and we don't see phonological errors quite often in saucer-shaped loss. We see it in high-frequency sloping sensory neural loss. So if we found such a case with saucer-shaped and with discrimination that's not quite satisfactory, then we suspect that there is another problem. Because this child should have excellent discrimination with such good aided responses. So there must be another thing which could be central problem.
Thank you for your comment. Thank you. So this is the diagnosis, and I think you all agree with Dr. Wafa. Yes. Yeah, I agree with you. The verbal and non-verbal, and yes, I agree with you. تفضلي.
I have a comment on the discrimination. If the child was not diagnosed early with this saucer shape, it's not that often, but sometimes we see such, because we are, even if there is one phoneme which is affected, we consider this as wrong answer. هو ممكن he could perform much better in life than in the speech discrimination score if he has this saucer shape, a milder, very early in life, without any correction till the age of 5, he will have some phonological error. If it was moderate, for example, for 2 or 3 years, it will. Sometimes we see this degree of hearing loss. Of course, this is not the usual case, but sometimes we can see not very high, not an excellent discrimination.
So I think you all agree that with this complaint and results, he is a candidate for further investigation. First thing, to look at the hearing aid. Do you think the hearing aid is satisfactory? I think it is satisfactory. But the problem is that the child used it late, because he started to use hearing aid at the age of 5 years. Maybe he has a hearing loss before. So do you agree that late amplification is a big problem for children, even with mild to moderate hearing loss?
He will acquire the habit to hear by his vision, not by his ears. He will depend on essentially on the visual cues. And this makes always the discrimination not as good as expected. So if he takes some auditory training, perhaps he will give better response. I think because he is visual cues here, he is dependent on the visual cues, such child, because of the late onset of
yes, and this is very important to focus that early amplification, even for development language learning abilities, is mandatory, where the plasticity is maximum. Dr. Aya, he has language assessment. He had, if you see, what is your comment on this child in language assessment?
This child needs a very full and comprehensive language assessment, including not just receptive and expressive vocabulary. You know, he needs all the comprehension subtests, all the auditory function, auditory listening subtests as well, and we have to exclude dyslexia, because some kids, it's not only language-based learning disabilities. He could also, or she could also have visual-based learning problems. So they need a very, very comprehensive assessment for language and for learning. As Dr. Wafa just said, because some kids, the total scores, even then the language assessment, you can get a total score that's average. But then when you look at the subtest, you find a score at a 3, and then at a 9, and then at a 5. And then I was just writing a report for a child this way. He had his sentence repetition at 3, his understanding oral instruction at 4 out of 10, which is the standard score is a 10. And he had his receptive language and expressive language at 9s and 10s. So if I get the total score, I'll get an almost average total score, which is very, very, very deceiving for anyone reading this report if they just look at the total score. So, and the issue here with this child as well is that 9 years old, he or she is in key stage 2 of learning. Key stage 2 of learning is a very, very auditory stage of learning. It's not based on visual, it's really based on auditory. So with this that we see, yes, they might really develop a lot of problems.
A case of dyslexia?
Could be, because some kids have both. It doesn't have to be one single diagnosis. We can have comorbidities in the same child, unfortunately. Yes.
Yes. Okay. We went to the final station, auditory processing disorder assessment, and he has a problem, as Dr. Aya said, difficulty in hearing in background noise. In quiet, he has no problem. And reading problems. This is the central auditory test chart. Dr. Amany, what is your comment? As you see.
First add to this, the delay in intervention في amplification, even if it is heredofamilial, he will acquire, as Dr. Iman said, and sometimes acquire modality, another modality to cope with, and be a good speech leader. And I was having a child that was at moderate, and I didn't look quite well to the audiogram. Starting the central test battery, it failed in it. When I returned back to the audiogram, it was a mild to moderate sensorineural hearing loss. So she was a very good lip reader. Children who is not early intervened usually take another modality to cope with the information. As regards the chart, we have auditory processing disorder, and again we have a problem in understanding in noise, which is selective attention, and in timing, in duration patterning of the information. Again, we can see that the AFT, the auditory fusion test, and the GEN test, they are tests for temporal processing. They are way beyond norms. So we have a temporal processing problem beside the selective attention.
Yes, I would like to focus that we did not do pitch pattern. We did duration pattern. Yes, Dr. Wafa.
Actually, he's going to score
Oh,
worse than this.
worse.
Worse. If he scores in all tests worse, because the attention deficit have a pattern, you have to suspect this from the very beginning. Not really, because if he's in top down with the attention, he'll go through all the tests. He will have abnormality in whole the test battery. But if it is like this, you can expect another attention problem. It is another, there is top down again beside this. The idea in this testing, we have to go through the memory and the attention.
Dr. Wafa, if he has attention, all the tests will be below the norm. We can exclude it very easily by doing auditory continuous performance test.
Yes. Yeah, we
Yes,
did this
I agree totally.
I agree. We did this, sorry for interruption, from the very beginning by the questionnaire and by the history taken from the child. And the minute you have to do this, you're going to go to the testing, you'll find all the scores low. Sometimes we don't go to the testing. We refer him first to be treated, and then we go for the testing.
Yes, let's go to the next slide so that time. We went and did, Dr. Aya, do you think that phonological awareness tests can help in this child? And what are your comments on the tests results?
The awareness tests, they laid, as we say, your baseline where you're going to set your program. So you understand where are his difficulties and how are you going to remediate them. Because in those children, whether, as Dr. Wafa was just saying, whether he might be ADHD, if he has APD, because some of those children have many actually problems at the same time. And with this child, honestly, with this very late amplification, we might find a lot of problems in his brain. The brain might accommodate, as everyone is saying, but it doesn't always have to accommodate correctly. Sometimes it accommodates and some areas are not working fine at all. However, phonological awareness tests give us direction. Where do we need to work? So I will not just work on his vocab and exclude his phonological awareness, because phonological awareness is step number 1 for reading. If he doesn't have phonological awareness skills, this explains why this child doesn't read. He needs blending and segmentation and working on each phonological processing skill for him to start reading, and he's 9 years old. If these are the scores, this is totally expected that he has a reading problem and a learning problem. So we have to work on these. They are very, very important and very crucial from the audiological point of view. And we also have phonological awareness tests in our speech and language assessments, because we also see things from the functional point of view, not just from the audiological point of view.
Thank you, Doctor. So the diagnosis, as you see, and I would like to know your comments, Dr. Iman. ABG, secondary to sensory neural hearing loss, comorbid with dyslexia, or what do you think? Or is it
as I told
loss and dyslexia?
Any to my mind, any child with sensory neural hearing loss, long-standing, whether or not he is using a hearing aid, he has some degree of temporal processing disorder and some degree of memory problem. selective attention also in noise. For example, and I do routinely for children with sensory neural hearing loss, temporal therapy, temporal processing, and selective attention routinely, even if they do not complain. If they are going to perform, for example, 80%, with this training, they are going to perform 95% or 100% without an extra effort from the phoniatrician or from the speech therapist or from the parents, just by training the brain to understand well the differences in temporal and in selective attention. For any child with this, and I think for this child, we have to start first with the training, the auditory training, whatever the degree, and then we are going to say if he has dyslexia with it or not.
Yes. Any of our distinguished panelists have a comment?
Well, there was a nice study to Dr. Anu Sharma, and she said that in loss of hearing loss in the early childhood, in a way, she did a long study, and she got an explanation that those children have auditory processing disorder, and this is why the shift of the age for the cochlear implantation started to be earlier than in the late.
But Dr. Aya, don't you think that the abnormal phonological test results suggest dyslexia, the presence of dyslexia?
No, there are different types. There are language-based, there are visual-based. But in this case, I want to point something else apart from the phonological awareness skills. Long-standing, unaided hearing loss, just as we were saying, cognition and hearing are two sides of a coin. So in this child, 5 years of not hearing properly, not having an aid, this would definitely affect his cognition somehow. In spite of, just as Dr. Rafa was saying, the normal IQ, if we assess the child holistically, we'll find some sort of a cognitive impairment. Just as you wrote down, Dr. Somia, a cognitive disorder of some point. His executive functions will not be as good as any hearing child or even aided child at his age. So this would affect his phonological awareness skills, his central auditory processing skills, his learning skills, everything. It's all because of the very long-standing unaided hearing loss.
Yes.
Added to it, Somia, as you know, that there are mirror image between the temporal processing and the phonological awareness, and this was studied and even was commented by Professor Music, that whenever we have a temporal processing, either there is a dyslexia or not, we are going to have some sort of phonological awareness.
Yes, I agree. The mechanism, of course, here sensory deprivation is very important in hearing, especially as Dr. Iman said, sensory neural will disrupt all the ascending pathway, resulting in abnormal processing. Management plan. Dr. Ossama, which one of them would you like to start with? Signal, compensatory, auditory training, or all of them at the same time? And what about dyslexia? You do it immediately, or what management?
First, we have to correct the hearing loss by providing a suitable amplifier for the child. Then we can consider
do you think
him,
that remote microphone or
Yes.
FM can help this
yes,
child?
Yes, especially in the classroom. Yes, especially in the classroom. Then the rest of the problems like dyslexia should be dealt with through the phoniatrician.
Dr. Iman, you have a comment?
I have a comment on the early use of FM system for these children. This does not give the brain the time to develop selective attention. We have been study before those who are using, had auditory training for speech and noise test and desensitization and start to increase the noise level, signal noise ratio. So they will acquire some sort of selective attention, which is not acquired by those who are using always the FM system, because they are not exposed to speech and noise most of the time. They have a good input with the speech. The brain does not have to develop other means to overcome this speech and noise problem he has. Yeah. And I do not recommend the remote microphone from the start. I start with the auditory training and give time for auditory training and see the results. If the results are not as expected in spite of a good training and of a good time for training, then I can go for the FM system, not from the very beginning.
Okay. Thank you for your comment, because I think auditory training to maximize neuroplasticity is a very important step.
Yes. And this is tripodal, Somia. We have to go to auditory training and the compensatory strategy with the other line and the environment. He is going to use the environment is important, but he is going to use the remote microphone merely in classroom. So if we have to have a good outcome from the very beginning, we have to do the three things. If we are, you can financially afford this.
This is example of phonemic training, I think, and the outcome, surprisingly, it is not always like this. But as you see, especially for phonological testing, he was far behind. He improved remarkably by auditory training.
Can I comment on just one thing also in the accommodation? Is that we're always addressing the accommodations for the child, but there is a far more important accommodation, is that the classroom itself. And this is very simple. It can even happen in a very big classroom that you ask the teacher to have the child sit next to her, sit facing her so that he can use his vision as well as his audition. Sit away from windows, sit away from fans, not near noisy kids. These are very simple and easy things that you ask, but actually they affect the children's performance remarkably, because they take away a lot of the speech and noise the noise that they have to work in, and it takes a lot of their distractions, particularly if they also have attention problems, as just Dr. Wafa was highlighting.
Yeah, thank you. Of course, early amplification in hearing impaired children is mandatory to prevent secondary ABG. Early as possible. And poor scholastic achievement with normal IQ should be referred for further investigations, including ABG. And we should be aware that dyslexia is a comorbid condition and is related to ABG. Even a recent study, 2024, said it's a common disorder with ABG and like ADHD intermingled with each other. Because I think ABG is not simple, a place with disorder. It's a widespread. You have an auditory, that's why neurobiology or neuroanatomy will let you know why it is intermingled with other disorders. Let's go with the third case. Dr. Iman Sadiq had a nice surprise for us. She will present this interesting third case. تفضل يا دكتورة إيمان. Really, it's very interesting. And I want you all to have ears and eyes to focus and help us to follow this case. Thank you, Dr. Iman. تفضلي. أنا محتسبة
So I shared, thank you, Dr. Somia. I shared this case with Dr. Somia and she asked me to present it in the, this case of two siblings were referred for assessment after 2.5 years of cochlear implant. The complaint was a delayed speech and language development as reported by their mother, especially the girl. The age of assessment, when they came to me, the boy was 6 years old, the girl was 5 years old. The age of diagnosis of hearing loss for the boy is at the age of 2 years. For the girl, because of the neonatal hearing screening, she was diagnosed early at the age of 6 months, and she had a risk factor of hyperbilirubinemia, while the boy doesn't have any risk factor. Both of them used hearing aids regularly before the cochlear implant, and they received rehabilitation in the same place 3 sessions per week for 1.5 years. And the age of implantation was for the boy 3.5 years, and for the girl 2.5 years. From this table, we can see that the girl was diagnosed earlier, and she was implanted earlier. And we expect, apart from the hyperbilirubinemia, that her results should be better than the boy. They received rehabilitation after CI in the same private center, 3 sessions per week. And at present, the boy can tell a short story with some phonological errors, and his behavior was normal and friendly, while the girl only can utter 2 single words, very simple words. And she was introvert and unfriendly. These were their aided response. And as you see, the speech discrimination for the boy was 64%, and with visual cues was 80%, while the girl was unable to discriminate even with visual cues. She cannot utter words she cannot understand. At this point, what do you think? What could be this cause? What should we do?
Are you asking why there is a difference between the boy and the girl? This is
the
your
boy
question?
is performing as expected, more or
Yes.
less as expected.
Yes.
Could be
Yes.
less than expected because of rehabilitation, because of IQ, whatever, but it's accepted as a result for CI.
Yes.
For the girl implanted at age of 2.5 years, receiving good speech and language therapy with a good mother, she supports both boy and girl. And in spite of this, she has a very good aided response, but cannot form or understand speech.
Almost all of the variables are the same, since it's the same
Except
family,
for
the same parents, the same everything. Just 1 year difference in the age of implantation
if you
is
look
not
at
that big. But the point that we have to put in our mind is hyperbilirubinemia.
Yes.
Hyperbilirubinemia
Yes.
is a catastrophe. It leads to poor speech discrimination, regardless you have auditory processing disorder or not. It's a very major problem leading to very
May I
poor
ask, when you have a case of
discrimination.
hyperbilirubinemia, do you expect very poor results with the cochlear implant?
Yes, I do.
A case of hyperbilirubinemia, do you expect?
I don't tell them that they are
لا,
going to
يعني
have.
I mean
poor-
in your practice, in pro practice, when you have a case of hyperbilirubinemia and they are implanted, do they give a fair, good response with the cochlear implant, or they do not give good response with the?
fair to poor. But I never expect
Like,
this
in my
patient
experience-
as one of the star patients. He will never be a star patient.
And in my
He will
experience, I
never
have
be a star patient.
very good
But are
performers.
you talking about hyperbilirubinemia
لا.
like 16 and 20 or like 30 and 35? If you are above 30, definitely you will have a very poor speech discrimination, and you do not expect very much from this patient.
الحقيقة أنا يعني in my practice I have very good results with
You know, in the
hyperbilirubinemia,
past, they were
moderate
denied
results
from
with
cochlear
hyperbilirubinemia,
implantation,
and
but
poor
now
results
they-
with hyperbilirubinemia.
they are
It depends, of course, on different factors, but I have good results. يعني if it's a poor or I have to tell the parents something like this, but it's variable. It could be good, it could be fair, it could be poor, but it's not always poor. What do you think?
That's what we tell them. But
أشو
لا اتفضل.
يعني apart from the audiological point of view, although in my practice in rehabilitation, I worked with several cases with hyperbilirubinemia, but I never took a 0% speech discrimination, honestly. In this case, honestly, if I see this, I would have to think from the psychological point of view and other causes of very impaired speech.
Yes.
So if her cognition is okay, I would think what's going on with her communication, her nonverbal communication. Is she on the spectrum? Does she have any autism somehow? Or is she dyspraxic? Because in some cases with dyspraxia, you would get exactly this problem, auditory neuropathy disorder. So I will have to think on other ways and other rehabilitations for this child, because you said she's unfriendly and introvert. Even in children who are not aided, not implanted, not aided, they get to have nonverbal communication and social smile and everything. So being an introvert and unfriendly with one sibling 1 year older only and implanted at the age of 2.5, this is not a proper expectation. So I would have to dig further into other comorbidities.
Dr. Somia, do you have?
Yes, I agree with Dr. Aya. I have to look for, first of all, auditory neuropathy, because hyperbilirubinemia may be associated with.
Do you think auditory neuropathy, cochlear implant auditory neuropathy, do not give good results?
Maybe because it is variable. It may give good results and may not. Maybe
Yeah, it could be the only cause of such
comorbid with other things.
comorbid with.
Comorbid
Do you see? I think also auditory spectrum disorder could be a cause.
could be another
What
cause.
about central? Is there a place here for central processing disorder, which could be a cause of such?
Maybe
Maybe.
she has auditory processing disorder,
Tab-
but usually it does not give such a catastrophic response.
Response,
Zero,
yeah.
Yes, 0%. It is more than one disorder, comorbid with disorder. Maybe auditory neuropathy plus central, maybe apraxia. So
I've seen patients with apraxia or dyspraxia. They cannot utter words, but they understand. What do you think, Dr.?
I was just going to say there are many types of apraxia.
Yes.
So you have sensory apraxia, you have motor apraxia, you have mixed apraxia, and it is also a spectrum. So you have mild cases, you have severe cases, and in this child, it's not only apraxia, it's hyperbilirubinemia. So you could have auditory neuropathy spectrum disorder. You could, and autism and apraxia are very, very close.
Yes.
We always say they're like cousins. So they
Yes.
happen together in kids. So I think this child needs to be not audiologically assessed only. She needs a multidisciplinary team of a proper assessment because her mother is doing everything. I think there's something else that we have to think outside the box in this child.
Okay. For this child, do you need further investigations or referral? Everything. Psychologist, podiatrician. Okay. Tama, because we are audiologists and we believe that we are the star of any diagnosis, so we did a cortical response for this child. For the boy, he gave this. This is the P1, which means that he can detect the sound. And then we have the acoustic change complex, which means that he can discriminate the sound. When you give a sound and there is a change in frequency, he detects the sound, he gives the P1, and when there is change in the stimulus, he gives another replicate of this P1, but smaller in. This was for the boy, which means he can hear and he can discriminate. What about the girl? The girl, she has a P1, but no ability to discriminate. So at this point, we are sure that she cannot discriminate. It's not a psychological problem. The brain cannot discriminate. That we give for these two, this is the P1, and there is no discrimination. We gave them 6 months of rehabilitation, of intensive rehabilitation, and the result is always the same. For the girls, it's just P1, no ACC. For the boy, there is the P1 and there is ACC, which is better than the previous one. What to do? She doesn't have speech, cannot understand speech. She has a cochlear implant. What to do?
What kind of training is she taking? What kind of training is she taking?
أخذت يعني we tried with auditory training with a multi sensory approach. يعني we send them to the phoniatric. They tried all type of rehabilitation or they can do with the child for 6 months.
And how is her other lines of communication, her non-verbal communication, was it okay?
الحقيقة هي she's looking يعني اللي أنا فاكراه إنها كانت she's looking at me, she's trying to understand but she cannot understand. حتى even I think the reaction to يعني
the facial expressions, the body language.
يعني not. But IQ was okay.
Non-verbal IQ. Did she do a cognitive assessment? Yes.
Normal IQ, يعني verbal IQ, non-verbal IQ, it was okay.
Okay.
What to do?
Well, we are discussing this. If we roll out some issues, if we roll by this age, the autism spectrum disorder, there may be other signs, so we can be rolled out. And the apraxia, if she can understood the innate language, could be rolled out. We are looking for auditory neuropathy spectrum and the central. Okay, I don't know, you can tell me if we can play with the parameter of the CI in cases of auditory neuropathy. If you did this and still there is a problem, we'll have to search for central, or to start training central because we don't have the SEC.
Dr. Wafa, and I was just asking for you because you discriminate between pre-synaptic and post-synaptic auditory neuropathy spectrum disorder, and we all know that a pre-synaptic gives different results than the post-synaptic. Do you think this could play a role here? Without any motor or other signs of connectors, يعني just specific for the ganglion. Okay.
I added this slide because you know I am. I think
you know, because there is difference when you prepare a case and you are not central minded, and when you are central minded.
I do really
is not
think
my
that this child
case.
needs to assess temporal processing, because temporal processing.
How are you going to explain this for the child?
Dr. Wafa, using non-verbal stimuli and by adaptation, just pressing on a button by the computer-based program, not by the usual way of testing, modified way of testing.
If she was able to do a non-verbal intelligence test, the non-verbal intelligence test has several steps that has to be explained, and if she was able to do all the parts of the non-verbal test, then of course you can do other tests with her that are not speech related and that are not hearing.
Okay. What type of rehabilitation do you think? Education. Sign language. Unfortunately, we have to start sign language for this child to have a way to communicate. Okay.
Yes, I'm sorry for being late. Children fitted with hearing aid or CI with average IQ and still have listening language should be referred for further investigations. And I think that that's all. Okay, thank you.